This is our Welcome to Medicare seminar. We're just going to be talking about general information. We're not going to go over specific companies or their specific plans and prices. That would be something we would do on a one-on-one basis with you. We can't do that during an educational seminar. And this should only take about 45 minutes, depending on the questions that you have. And we can go from there. So Senior Connection, while it sounds like we are a dating website, we are not. We are an insurance agency, and we are contracted in the states of Kentucky, Indiana, and Illinois. We do help with people who are turning 65 or aging into Medicare after retirement. We are not associated with the federal Medicare program or with Social Security, and no agent or agency is. So if you hear that, if they say that, they are mistaken, because there are no agencies that are contracted on to work with those agencies themselves. So with Medicare, it is the federal program that is providing your hospital and medical coverage to you. You are eligible at 65, or if you have been awarded it due to disability. Now with disability, you have to be on disability for 24 months before you are eligible, unless you have a specific disease such as ALS, which is Lou Gehrig's disease, or end-stage renal disease, or a terminal cancer. Then you can get that award much sooner than the 24-month waiting period. It is run by CMS, which is the Center for Medicare and Medicaid. Benefits are controlled by Congress, which means it would take an act of Congress to make changes. Nothing is going to happen overnight. Despite what the politicians say, it takes years for those things to make changes and actually implement them from that point on. And Medicare, to make it confusing, is broken down into letters, and there are multiple letters involved, whether it's a plan or a part that you have to be aware of with your coverage. Now, under Part A, if you have traditional Medicare, you have Part A is your inpatient hospital stay. This is basically the room and board, nursing staff, skilled facilities, hospice, and limited home health care. You have earned this premium free based on your working history or your spouse's working history of at least 10 years or 40 quarters. And that does not have to be a consecutive work history. You have a deductible with Part A that is $1,408 per stay in the hospital. It's not an annual deductible. It is a per stay deductible in the hospital for a specific benefit period. If you go into the hospital as an inpatient, are released, and 3 months down the road, you go back into the hospital as an inpatient, that is a new benefit period, and you will have that deductible again. If you go into a skilled facility after an inpatient stay, qualifying inpatient stay, Medicare will pay for the first 20 days in a skilled facility, and you are responsible for a copayment for days 21 to 100. Your copayment is $176 per day. Now, these out-of-pocket costs are if you only have traditional Medicare. We're going to talk about ways to mitigate those costs, but if you only have traditional Medicare, this is going to be your out-of-pocket exposure. Now with Part A, you've got your inpatient admittance. To be admitted as an inpatient, you have to meet certain guidelines, certain criteria. You can't just ask the provider to put you in as an inpatient or an outpatient, but you have to meet certain criteria. And there is what's called a 2 midnight rule or a 3-day rule. I kind of like to think of it as a vacation, as a 3-day, 2-night stay. But it can get confusing to the hospital administration and the hospitalist as to where to code you in order to receive that inpatient hospital stay. When in doubt, ask questions. Make sure that you understand what your status is in the hospital, because it can have a difference in your out-of-pocket expectation down the road. To have skilled care paid for by Medicare, you have to have that qualifying 3-day stay in the hospital as an inpatient. If you are an outpatient in the hospital and then go to skilled care, your coverage is not the same. It is different. You want to make sure that You understand if you are inpatient or outpatient. Sorry. Home health care is limited to skilled care. Many people, when they are going home after a health event, the kind of care that they need in home is the custodial care, cleaning, grocery shopping, bathing, dressing. Those are custodial needs. It is the skilled care that is covered by Medicare. If a nurse practitioner or a licensed practitioner is coming to your home to provide therapy, whether it's occupational, speech, or physical therapy, those are skilled care needs that are provided in home, which is honestly cheaper for everyone if the services are provided in home rather than in a facility or at the hospital. And then hospice care is provided in the home, can be provided in the home or at a facility, and that falls under Part A. So your Medicare Part B is everything else. It's the doctor visits, lab work, durable medical equipment, outpatient services, and surgeries. Now, Part B, you do have a premium for. If you are drawing Social Security, your premium will be deducted on a monthly basis. They will automatically draft it out of there, out of sight, out of mind. If you are not drawing Social Security because you're going to delay that Social Security because you want to maximize your benefit, or you just simply don't need to draw Social Security, if you sign up for Part B, you will be billed on a quarterly basis, and just write them a check on a quarterly basis. They do have an option for a bank draft, a monthly bank draft. It's called their Easy Pay system. It is not easy setup system. It is a little bit of a challenge to get that set up. So most people that we work with just pay for the quarterly premium and don't worry about it there. I've not met too many people that set up their Social Security on a bank draft due to the complexities of getting it set up. Now with the Part B, you have an annual deductible of $199. Part A's deductible is per stay. Part B's deductible is annual. It is often split up over multiple doctor's appointments. You would rarely pay the $199 at one time. So if you go to the doctor in February, they might bill you $100 for that visit. And then you go back in May for a follow-up, and they bill you the remaining $99. And then your Part B deductible is satisfied. After that, Medicare is paying 80% of the approved charges, and you are left with the final 20%. Medicare's 20% is unlimited. They will pay, Medicare's 80% is unlimited. They will pay 80% of approved charges, whether it's $100,000 or $1 million. But that means that your 20% is also unlimited. You will pay 20% of those approved charges. This is your largest area of exposure under Medicare. With your group insurance or your individual plan right now, you have an out-of-pocket maximum. It could be $5,000 or $10,000, and when you reach that amount, you have no additional out-of-pocket. With this 20%, it keeps going. When you have an office visit, it is, maybe $100 or $200. That's not a life-changing amount of money that you have to pay. If you have a knee replacement or a hip replacement, that's all under Part B, and it can be thousands of dollars because you have the surgeon fee, you have the surgical center, you have the anesthesiologist, you've got rehab, you've got your durable medical equipment. All of those services are for one event of the year. And then anything else that you have going on continues to add on to that. So this is the largest area of exposure that you want to protect. And again, we're going to get to that in just a few minutes, but there is actually 20% of the nation only has traditional Medicare, which still blows my mind, but they only have traditional Medicare A and B, and they pay for any services that they have out of pocket. Now, the standard premium for Part B is $144.60 per month. And again, that's either taken out of your Social Security check or you're paying them on a quarterly basis if you are not drawing Social Security. If you are a higher income earner, then you will pay a higher Part B premium. They are looking back, they being Social Security, looks back 2 years on your tax return. Your adjusted gross income 2 years back will determine your Part B premium. 2020, they're looking at your 2018 adjusted gross income. If you are above the thresholds for higher income, you will pay a higher Part B premium. If your income drops down to the standard income, then your Part B premium will also adjust accordingly. And if it moves up, if your income goes up due to dividends or you win the lottery and it's taxable, those events could increase your Part B premium. So it can adjust up and down. Again, Medicare pays 80% of your approved charges, and Medicare is nationwide. There are no networks to be aware of. You can go anywhere in the nation that the doctor accepts Medicare. We get questions a lot about what if the doctor doesn't accept Medicare? But that is a possibility. If you are seeing a provider right now that accepts Medicare patients, when you turn 65 or you go onto Medicare, you can continue to see that provider. You might run into trouble if that provider retires, which usually in that situation, the doctor has found another provider to take on their patient load. If the doctor passes away suddenly, you could be scrambling to find another provider that is accepting new Medicare patients. Oftentimes they will stop accepting new Medicare patients until their patient load is under control or it's within certain amounts so that they can provide that proper care for everyone. But if the doctor or facility accepts Medicare and they're accepting new patients, you could go anywhere in the country. Now, in order to mitigate some of those out-of-pocket exposures, you have what are called Medicare Supplements or Medigap plans. These are literally plans that you purchase that pick up the gaps in Medicare's exposure. They are lettered. To add to the confusion, they are also lettered. A Plan F, for example, Frank, Plan F as in Frank, has been the most popular plan for many years. For those of you who are just turning 65 in 2020, Plan F is not available to you. It's going to be a Plan G that is your go-to plan. Plan G is in girl. These plans, all of them, are standardized. If you are looking at the same plan letter, Plan F, Plan G, Plan N, Plan A, they are standard. Any company that is offering those letters has to offer the exact same benefits. Your benefits, your claim service, the turnaround, it's all the same. The premiums are all over the map. You could have a Plan G for a 65-year-old female at $100 a month with one company. It could be $150 a month with another company. The benefits of the plan are exactly the same. There are companies that offer gym memberships as a part of their incentives and additional value-added services, but make sure you're looking at what you're actually spending to get that. Are you paying 50% more in premium so that you can have a gym membership, or is there that value there that you see it's worth that additional cost? Now with Medicare Supplements, you're going to have that higher monthly premium. You've got a $100 per month premium that you're going to pay. A Plan G, for example, your out-of-pocket exposure is the Part B deductible. You are going to pay the Part B deductible, that $199. After that Part B deductible is met, you have 100% coverage on approved charges. If Medicare approves the charge, your supplement follows suit, no questions asked. You're going to have that coverage available once that $199 has been satisfied. So you're going to pay a higher monthly premium. You pay very little out of pocket as you go. And again, the supplements are nationwide. If wherever you go, The supplement follows in behind you, no questions asked. They're going to pay the responsibility that they have based on the plan letter that you choose. Now with Part C, these are Medicare Advantage plans. These are private insurance companies that are contracting with Medicare on an annual basis to provide that coverage to you. You have an HMO option, a PPO, and a private fee-for-service. You've got lower monthly premiums on these plans, but you have co-payments for almost all of their services, and those co-payments are going to add up to an annual out-of-pocket limit. It's very similar to your group insurance. They are managed care plans. An HMO is the most restrictive kind of care because it is in-network only. If you go out of the network for non-emergency services, you pay 100% of the cost. If it is an emergency or urgent care, they have to accept you in-network. But if you are traveling and get a sinus infection, that's not an emergency. You're going to pay 100% of that cost. If you are traveling and you break your leg, that is urgent care. They will provide in-network coverage to you, in-network costs. You have a PPO, which is in and out of network coverage. It's going to have a slightly, usually has a little bit higher premium than an HMO, but there are some very low cost HMOs. And you have more flexibility going in and out of network. If your doctor is not in network, you can still see that doctor as long as they will accept that plan and do the billing to that plan. You don't have to have referrals for HMOs or the PPOs. That is something that's changed in years past. And then what we have in Medicare is a private fee-for-service. There are not many in this area. Personally, I feel they're kind of complicated. You can go to any doctor that will accept the plan, and they have to accept the terms of the plan. But you have to verify that they're going to accept the terms of the plan every time you see them. Just because they accept it this month does not mean that they are going to accept it next month. So there's a little bit more responsibility on your plate to be aware of. So really we work with the HMOs and the PPOs, and there are great options on all sides of those fences. Now with the drug plans, that is Part D. Just remember D for drugs. These are the outpatient prescriptions that you are self-administering. Your high blood pressure medicine, your cholesterol, diabetic medication, thyroid. You are taking these medicines on a regular basis or even semi-regular. It's something that is prescribed to you and you are taking at home. If you're taking medication or given medication as an inpatient in the hospital, that falls under Part A. If you are an outpatient in the hospital or you're taking medication at home, the drug coverage falls under Part B. These plans have monthly premiums and they have tiered co-payments, meaning you're going to have out-of-pocket costs for your prescription. Now, these plans are voluntary. Our government's idea of voluntary is that you don't have to have a drug plan. But if you don't have a drug plan and you don't have other credible coverage, such as your active group insurance, the VA, if you have VA, that is credible, or if you have retiree coverage that includes prescription coverage, those are credible options. But if you don't have any of that and you don't have a drug plan, then in the future, when you enroll in one, you are going to be penalized for every month that you could have had a drug plan and you did not. And that penalty stays with you for life. The penalty is 1% of the national average premium. This year, I believe it's 38 cents a month. So if you went for 1 year without a drug plan, your penalty is going to be about $4 to $5 per month. Now, if you are someone in the higher income category and you have to pay that higher Part B premium, you will also have to pay a higher Part D premium. You're going to have a premium adjustment there as well. So you want to be aware of that. We've got clients that don't take any medication or take very low cost medication, and they have a drug plan just in case. just in case they get put on drugs and just to avoid the penalties in the future. They just don't want to risk that potential penalty. We've got clients that take no medication or take very low-cost medication, and they're assuming the risk. They don't have a drug plan. They'll fill prescriptions and pay for it as needed, or if they ever need to buy a drug plan in the future, they're just going to pay that penalty and they'll deal with it at that time. We are not going to tell you you have to have a drug plan, but we are going to make sure you understand if you do not take one, you will be penalized in the future if you don't have that credible option. Now, for those of you who have VA available, you do not have to use the VA to fill your prescription, but you do have to be signed up with them. You do have to sign up with the VA and have it as a possibility, but you don't have to use them for your coverage. Now, the drug plans are available as a standalone drug plan or those that are integrated in the Medicare Advantage plan. So if you have a supplement, then you could have a standalone drug plan to go in coordination with that. If you have a Medicare Advantage plan, it's going to be kind of all in one. You've got your medical and your drugs all together in that plan. This year in 2020, we have 28 standalone drug plans available. Every single one of them is different. They all cover drugs differently. They have different premiums, different co-payments. No plan covers every drug. No plan does that. So when we're looking at your specific medications, we want to know what they are so that we can find a plan that's going to be most cost effective for you. Which of these 28 plans is going to have your lowest out-of-pocket cost? These plans do not do anything special for you on the drug plan side of it. It's just who is the most cost effective for your drugs right now, because these plans change throughout the year and they change for sure at the end of every year. You're going to be looking at these January 1 to December 31st. If you come on to Medicare in July, then you're going to be looking from July to the end of December, and you're going to reevaluate your needs in the annual enrollment period for 2021. So you get to do it, and then you get to turn around and do it all over again. You don't have to make those changes, but you want to be aware of them to see what the changes are and if you're going to be spending more money than necessary. There is absolutely no reason to spend more money for your health care and your prescriptions than absolutely necessary. The money is better off in your pocket than in the insurance companies. If you have heard of the donut hole, it was supposed, from what we were understanding, it was going to go away. The donut hole they were getting rid of the donut hole. Well, they have and they haven't. The donut hole is still there. It's still a possibility. The donut hole means that you have reached a specific amount of time, or you've reached a point in the year where your prescriptions are now going to start costing you more money. The insurance company has paid a specific amount of money, and then you have to start taking on more of that cost. So it's going to shift from a lower cost to you to now a higher cost. But when you're in the donut hole, your prescriptions are capped at 25% of the full cost. Whether it is a brand or a generic, your cost is capped at 25% until you reach another threshold where you're going to go into catastrophic coverage. We'll get into more detail with that in a one-on-one appointment because it's a lot easier to see with your specific medications. But I can tell you, if you are on a handful of generics, you're not going to go into the donut hole. Generics are just lower cost. You're going to stay out of the donut hole. If you are on 2 or 3 name brand drugs, you're going to go into the donut hole, especially if you have insulins. Insulins are still very expensive on a full cost basis. Even if you're only paying a small portion of it for your copayment, it's the full cost of the drug that determines when you're going into that donut hole. The insulins that we see are between $600 and $800 per insulin per month. And most clients that we work with have not 1 insulin, but 2. If you've got a slow-acting and a fast-acting insulin, you're filling those prescriptions, you're looking at between $1,200 and $1,600 per month that is working towards getting you to the donut hole. Your generics are going to be a couple $100 maybe for those costs. So generics are inexpensive for the most part. There are ones that are high, but your brand name drugs, they are higher cost, and they're trying to move everybody away from brand names. Unfortunately, they're just not available for all the different medications that people are taking right now. Okay, so why you're here today, most likely, do you need to have Medicare? Well, if you are still working, if your employer has less than 20 employees and you are going to continue working, yes, you need to enroll in Medicare. Medicare is going to be your primary insurance, and your group will be secondary. So they will work together. If your employer has more than 20 employees, you are going to have your group insurance as your primary. You can enroll in Part A because it's premium free. Most people do. But you may be able to delay your Part B enrollment while you are actively working. And that is because you have credible group coverage. As soon as you are not working, if you go into retiree status, you are no longer an active employee, or if you drop down to part-time, and so you're going to lose those benefits to your employer, that's when you want to enroll in Medicare. If you delay that enrollment, you could face penalties in the future. If you are actively working, you can delay that enrollment into Part B and save yourself the $144 a month. You will want to coordinate with your HR department how they coordinate with Medicare. Most large employers that we work with in the area, basically every employer that we have spoken to, allow you to delay your Part B enrollment. Vectren, EVSC, both of the universities, Whirlpool, Alcoa, Anchor Industries, all of those companies allow you to, OneMain Financial, they allow you to delay that Part B enrollment while you are actively working. As soon as you retire, you go to the Social Security office to enroll in Medicare and start up that Part B later on. Now, I will say, if you have an HSA, a health savings account, and you want to continue working past 65, and most importantly, you want to continue contributing to your HSA. That means you are funding your HSA. You cannot enroll in Medicare A or B. If you are contributing to your HSA and you are enrolled into Medicare, you will face penalties. Will they actually follow up on that because the IRS is so busy? I don't know. But I'm not going to let you leave here without knowing that if you have HSA contributions and you're enrolled in Medicare, you will face penalties, or you could face penalties. Now, if your employer is contributing to your HSA, they have to stop that as well. You cannot have any contributions over 65 into your HSA. The caveat to that would be if you are contributing for a younger spouse. If you are 65, but your spouse is 63, and you are contributing to your HSA as a family, you have a family contribution amount and an individual contribution amount. You turn 65 and are enrolled in Medicare, you can change your contribution down to that individual amount and continue to contribute for your younger spouse, and you will not be penalized for that. Both of you have the ability to use HSA money for its intended purposes. But if you are contributing over 65 for yourself, you could face penalties. Okay. Talk to your HSA administrator. Your employer probably won't know that. Most employers don't because they rely on their HSA administrator to keep on top of that and to know those rules. So just talk to your HSA administrator. If you have an HRA, or an FSA. They don't follow any of those rules. There's nothing to worry about with those. It's only the HSA, the Health Savings Account, that has these penalty rules. Now, when it's time to enroll in Medicare, you're going to talk to the Social Security office. People get confused here because they're afraid that they have to enroll in Social Security. Yes, you talk to Social Security to start your Social Security benefits, but you're also going to talk to them to enroll in Medicare. You're going to, my suggestion is to go on ssa.gov. You can enroll in A and B together at the same time online, or you can enroll in A only online. If you are someone who is going to work past 65 and you're going to be enrolling in Medicare at a later date, you will have to contact the Social Security office at a later date. You cannot enroll online, at least right now. With COVID and everything going on, they are working on changing some of their enrollments, but they've not finalized all of that. I don't know if they're going to allow you to do that online. Since the office is closed, you cannot go into the office, but you can call. The number that is on this slide is the local number, and we've had clients have success with getting enrolled in Part B. They can give you a fax number to send in your Part B forms, because there are forms that you will have your employer fill out when you are delaying your Part B enrollment. You're going to have a section to fill out, and your employer has a section to fill out. And the reason they have to do that is to show that you've had credible coverage from this time that you've been 65 and over, and now you are enrolling in Medicare. And that helps, that avoids any penalties from not having that credible coverage. But if you are turning 65 and you need to start both Parts A and B, then you can go on to the Social Security website and enroll in that together. If you are drawing Social Security prior to age 65, you will be automatically enrolled in Medicare A and B. You don't have to do anything to reach out to the office. They will send you your card 2 to 3 months in advance. If you are working and you don't need Part B, then you'll want to follow the instructions on the card that they send you, so you don't start getting charged for that Part B premium. But if you are not working, you're retired, you're drawing Social Security, and you need to start Medicare, they're going to automatically mail that card to you, and you've already completed that step. If you're delaying your Social Security and you need to start Medicare, you have to reach out to Social Security and let them know that you want to get that started. They don't automatically know that you want to enroll in Medicare. And Social Security would request 2 to 3 months in advance of your enrollment. That way they have time to get everything processed and get your card sent to you. Now, which way to go with that coverage? Because you do have options here. There's really no better, one option is not better than the other. It's what you are comfortable with. In one way, you can structure your coverage with traditional Medicare, a supplement, and a standalone drug plan. You're going to have higher monthly premiums because you have your Part B premium that you're going to be paying. You're going to have your supplement premium that you will be paying. You're going to have potentially, well, you'll have at least your Part B deductible that you have to pay. And then you're going to have premiums and co-payments for your prescriptions. This option with Medicare and a supplement is nationwide. Any doctor that you want to go to accepts Medicare, your supplement follows in behind you. The other option you have is the Medicare Advantage plan. You still have to pay your Part B premium. So you're going to have that no matter what you do. You pay that Part B premium. But with the Medicare Advantage plan, you could have a zero premium plan. You'll see these on TV oftentimes talking about zero premium, zero copayment, zero deductible, zero prescriptions. There is no free insurance. You are going to pay for it somewhere. Now, there are plans that have a $0 premium, but you have copayments for doctor visits, for lab work, outpatient services and surgeries, per day in the hospital. All of those copayments are going to add up to an annual limit, depending on the plan, could range from $4,800 to $10,000, depending on if the services are provided in network or out of network. Because remember, these plans have networks, in and out of network coverage. A doctor visit in network could be a $5 copayment. A doctor visit out of network could be $30 copayment. You're going to have the option for dental, vision, hearing, gym memberships, over-the-counter prescription and benefits. Over-the-counter benefits are available. Those are value-added services to these plans. So when you see that on TV, these are the Medicare Advantage plans. You're going to pay a low monthly cost. You pay as you go. These plans that include drug coverage, you're going to have copayments for your prescriptions. Your copayments for your prescriptions do not apply to the medical out-of-pocket limit. And your copayments for medical services do not apply to getting you into or out of the donut hole. Those are two separate sections within the same plan. So they don't help or hurt each other. Medicare Advantage, I like to think of it very similar to group insurance. Networks of providers, copayments, out-of-pocket maximums. Neither option, whether it's traditional Medicare and a supplement or a Medicare Advantage plan, neither one is better than the other. It's what you feel is in your best interest and what you are comfortable with. It's pay now or pay later. One way you are going to pay. It is insurance. It's like gambling. The house always wins. They have it figured out. Our most expensive supplement, last resort effort that we have is nearly $4,000 a year. And that's for someone who's over 71 years old. So under a supplement in that situation, you are guaranteed to have to pay that much money, whether you pay it, whether you use the plan or not. For most people, your premiums are going to be in the $1,200 to $1,500 range. As you get older, your premiums will go up. Under the Medicare Advantage plan, you could end up paying nothing for the entire year because you have a zero premium plan and you've never gone to the doctor. If you are diagnosed with cancer, you're going to hit your annual limit in that first month because the chemo or radiation copayment is 20% of the cost across the board. So you could spend a lot of money in that first year or in that first couple of months. That's a very extreme example. But it's the one way that you can meet that out-of-pocket limit and have that additional cost. But it is up to you what you are comfortable with. There are great plans on both sides of the fence. With your Medicare supplements, when you are first coming on to Medicare, you are guaranteed issue. Pillar of health or on your deathbed, you can get the supplement that you want, no questions asked. As time goes on, your premiums are going to increase. And we like to get 3 to 4 years out of a plan before it's taken premium increases to where we could save you money moving to a new company. But that new company can say no. They can tell you no based on your health. If you've had a heart attack, cancer, a stroke, if you've got emphysema or COPD or a degenerative disease, those could be knockout questions, or we have to wait a specific time frame. A heart attack or a stroke, it's a 2-year minimum. So if we know you had a stroke 2 years ago, then we might be able to move that plan to this new company, but they can say no. Your guaranteed insurance is Medicare. The supplement is secondary, and it's a voluntary plan that you're purchasing. Now, that doesn't mean you're going to lose the current plan you have. You can keep that. It's just that your new company that you want to go to might not accept you based on your health conditions. With Medicare Advantage plans, when you want to change, you can do that every year at the annual enrollment period. You'll see your TV and your mailbox be inundated all over again, because right now, if you're close to Medicare, you're being inundated with information. It happens again at annual enrollment, because that's when the Medicare Advantage plans can get new enrollees and change their plans. The only question that knocks you out of changing from one Medicare Advantage to another is if you have end-stage renal disease. If you have end-stage renal disease, you will not be able to change your Medicare Advantage plan. We don't have a lot of clients that fall into that category. I could count them on one hand who works with us that is affected by that. If you are in a Medicare Advantage plan and you want to move to a supplement, depending on the time frame, one, you have to do it during annual enrollment, but you have to answer those questions. The caveat to that is if you are in a Medicare Advantage for the very first time, no matter when it is, the very first 12 months that you are in a Medicare Advantage plan, you can get out, no questions asked. You can go to Medicare, a supplement, and a drug plan, no questions asked. If for any reason you do not like that Medicare Advantage in that very first 12 months of your trial period. Now, on the other side of that, you start off in a Medicare supplement and you want to go to a Medicare Advantage, you have to wait until the annual enrollment period. That can be done at the annual enrollment period. Trial period can be changed anytime in that first 12 months. Moving from a supplement to a Medicare Advantage plan, that can only be done during the annual enrollment period. And that happens every single year, October 15th to December 7th. These are your enrollment periods. When you are first turning 65, you have your initial enrollment period, the 3 months before, the month of, and 3 months after to make your decision. When you're on Medicare, you have the annual enrollment period option that's available every single year, October 15th to December 7th. Plan changes take effect January 1. A special enrollment period. This would be when you are retiring, or if you are moving, if you are put into a skilled facility or going into a long-term care facility, whether it's a short-term duration or long-term duration. If you're going into or out of that facility, you have a special enrollment period that takes place during the time of that event. And then we have an open enrollment period that is January 1 to March 31st for Medicare Advantage plans only. If you are in a Medicare Advantage plan and let's say in February you find out that your doctor has dropped out of the network for the plan that you're enrolled in, you can change to a new Medicare Advantage plan. You can change from one Medicare Advantage plan to another. Those are the only changes that you can make at that time. Okay, so if you or someone that you know has trouble paying for your prescriptions, low income subsidy or extra help is available. This is a federal program through the Social Security Administration. You can fill out the application online. It used to have a paper application, but I think they have completely done away with that. So you either do it online or you would have to call to apply for extra help. And this helps with paying for your prescriptions, just help with paying for the drugs. If your income and assets are very low, then Medicaid may be an option. We would refer you to SWORCA for help applying for any Medicaid assistance and the different levels of Medicaid that are available. Medicaid is a beast unto itself. We do well to stay on top of Medicare, so we don't get involved in the Medicaid applications. But once you have applied for it and you are either awarded or denied, then we can come in and find out where else you need to fill in any gaps, or do you need assistance or plans in there to help out with any of that additional coverage. So those are the resources that are available to you. And then we've got, oh, no, that's fine. This is my lovely team here. Henry, Cindy, and Audrey are the sales agents. So when you are meeting with us, they're going to go over the supplements and Medicare Advantage plans with you. Brenda and Lainey are going to go over the drug plans. They're my drug plan experts, and they will handle questions and enrollment on the drug plans. Pat, myself, and Janet, who's not pictured here, we are the support staff. So we make sure that the agents and the PDP people have what they need so that you guys have what you need. If you want to watch this again, I can email this link out to you, or we have this seminar from a couple of years ago on our YouTube channel. You could go to our Facebook page, we've got information, or to our website. We post articles and different information on there. I really appreciate your guys' time today.